anything like that. But I'll turn the time over to Dr. Blatter and I'll let him dive in and ask questions, guys. It's open, be free, we're chill, get lots of food.
All right, thank you very much. Thanks for having me. Everybody here okay? I don't have a mic, but I'll try and project. You good? Okay. Yeah, I'm Michael Blatter. I grew up in southern Utah, actually, so I'm from Utah. I moved out of the state for some of my training in Nevada for medical school and then to Cleveland, Ohio for orthopedic surgery residency. And then I was in North Carolina at Duke University for orthopedic trauma fellowship. After that, I moved back to the Salt Lake area. I did another fellowship in joint replacement surgery, and I joined the Hoffman Arthritis Institute. So I'm in private practice. I work in Salt Lake, Layton, and sometimes as far north as Ogden, but I'm associated with the Holy Cross Hospital system in Salt Lake and Davis, of course, if you guys are aware. So this should be interactive, so please interrupt me if you have questions. I'll kind of run through what I have, and then I brought some little show and tell stuff for you guys who may have seen some of this stuff, but I'll kind of explain these different instruments and these different implants that we use to treat different injuries. Today we're focusing primarily on the pelvis and hip fractures and femur fractures, but feel free to ask any questions about anything that comes up. So this is kind of an overview. We're going to start with femur fractures, of course. Polytrauma patients, the initial management to definitive care is, we're going to kind of go through the whole spectrum of that. DCO, or something we call damage control orthopedics, which I'll explain what that means, versus early definitive care. And then we'll kind of finish off with some pelvic injuries as well. So I'm going to go through the femur bone first. The femur bone, of course, meets up with the pelvis in the socket we call the acetabulum. You may have heard that term, but the femur bone articulates with the pelvis through that socket. When we talk about the femur bone, it's the biggest bone in the body. It has a variety of muscle attachments which are important for us. Fractures, there's kind of a generalized term that we call hip fractures. Hip fractures is very broad in my mind and can mean a variety of different things, but it's usually the upper end or the proximal end of the bone that's broken is what we call a hip fracture. Hip fractures can involve the head of the femur, which is this portion here, the neck of the femur, and then a region in between these bony prominences we call trochanters, a greater trochanter, a lesser trochanter, and this intertrochanteric region is where you can have a lot of hip fractures that occur. Or even below that in something we call subtrochanteric hip fractures, all the way down through the femoral shaft. And then this meets up, of course, with your tibia to form your knee joint where you have these medial and lateral femoral condyles. All these different areas can fracture based on the mechanism of the injury. All of them have different treatment options based on the amount of displacement that can occur when the fracture happens, the age of the patient. So all of these things factor into how we manage these fractures. So that's kind of what I just went over there, the different types of hip fractures that we see commonly. So treatment options, like I said, there's several different options to treat hip fractures. Some are as simple as small little plates and screws. These can go and attach to the side of the bone and go up into the head of the femur in order to stabilize it with screws and a plate construct. You have rods that can go down inside the intramedullary canal of the femur and go all the way down to stabilize the fracture. All the way up to hip replacements where we replace the hip with a new socket, a new ball, and this would fit into the patient's pelvis where we impact this into place and create a new hip socket. These implants in the femur go down inside of the bone, and then we remove the damaged portion for like a femoral neck fracture and replace it with metal and plastic to recreate a new hip. So this is kind of a wide variety of what we go through to fix these and different screws that we use for those. The age of the patient is really important when it comes to hip fractures. Commonly, these are elderly patients, ground level falls that you guys probably see a lot of. But they can be high level or high speed impact type accidents in younger patients. Young patients, when you break say you have a femoral neck fracture in a young patient, it breaks through this portion and it kind of is like, I describe it to patients, the ice cream falling off the cone. When that happens in a young patient, you can fix the fracture, and the younger patients have much more high probability of healing with fixation rather than replacement. When you age, your blood supply to the femoral head is somewhat limited, and so if the ice cream falls off the cone and you try and put it back, the likelihood of that healing is pretty low, and that's where I typically go to more of a hip replacement procedure. It's one that I can do fairly quickly, remove the damaged portion of the bone, and then get the patients up and walking the same day of their surgery. So there's a lot of benefits to the different types of implants that we use based on the patient's age and the fracture that occurs. These patients typically will present classically as their leg is shortened and externally rotated. If you see a patient down with their leg externally rotated and it appears short in comparison to the other one, that's a good indication that the patient has some type of fracture about their hip. What do we do? You guys are very well aware of this. The ABCs, and sometimes taken out to D, E, and F. From an orthopedic standpoint, everybody thinks we care about three things. One, is the patient alive? Two, does the patient have bones? And most of them do. And are they cleared for surgery? That's kind of my thoughts, ABCs. I want to know if the patient's alive, do they have bones, and can I operate and fix them up? So this is really the home run. These next two slides are really the critical message of my whole talk today, is that one, fracture care affects the overall patient status. So when a patient has a fracture, whether it's a low energy or a high energy mechanism of injury, how we treat that fracture can affect how the patient recovers. Also, the overall patient status should affect how I treat the fracture. Now, those are two different things, and I'm going to try and explain what's the difference between those things, but what happens to the patient in their current state, like a polytrauma patient with multiple other injuries, should change how I help that patient as opposed to just going right to, does the patient have bones and should I fix them right away? How I fix them may impact their overall status after, and so that's important. And this is where we come into some of these different early fixation, and we'll kind of go a little bit of history, through some history of how this has evolved over the last 50, 60 years. So benefits of early fixation. So getting a patient that has an injury and getting them fixed up, usually less than 36, sometimes even less than 24 hours. We can mobilize the patient quicker. We have lower rates of pulmonary complications, which is a huge issue that I'll go into in a little bit. And then their hospital stay, their ICU stay, all can be somewhat lessened or decreased by the quicker I can get to them and get them fixed up. So here's kind of a little schematic of what kind of happens. We have a patient that has some type of musculoskeletal injury. They get pain, of course. You have a sympathetic discharge, which can release all kinds of inflammatory mediators. Patients can bleed. You can have hemorrhage, of course, with some of these fractures. They can go into shock if you have a significant amount of blood loss, which can lead to end organ hyperperfusion, again, increasing the inflammatory response, higher morbidity, higher mortality. So by stabilizing these fractures, we can, one, help eliminate some pain for the patient, we can reduce blood loss, and overall that can decrease the mortality and morbidity from these patients. So there's something that we commonly refer to as a second hit phenomenon. Anybody heard of that term before? A second hit phenomenon, I'll kind of explain this, is basically patient has a fracture and injury, we get that inflammatory response. That can lead to pulmonary complications. If the patient has a head injury, it can lead to other injuries from a neuro status. And so patient has an injury, I go right to, this image is supposed to kind of depict me fixing the surgery, fixing the bone with surgery, and that can increase insult to the patient, or that inflammatory response can have a second hit, or it can be increased by my intervention to try and help the patient. I can actually hurt the patient. cause pulmonary embolisms, and eventually some organ damage. So we need to kind of be careful about how quick we get to these patients and what we do to help them. Polytrauma patients can be defined by different organ systems and something called an injury severity score. And I'm not going to go through all the different, but there's a lot of different areas that we look at, and then we give these patients a score. The higher that score, then it's more of an indication for us to kind of temporize the fracture rather than fixing it right away. So why do we stabilize the fracture? One, we can do that with a variety of things. You have a traction device here. We have a pelvic binder that we'll go into a little bit. Stabilizing the fracture helps reduce the pain, and it helps to decrease hemorrhage and that overall inflammatory response. Fat embolization is something that can happen from the bones going to the lungs, and you can have an embolus of fat that goes to the lungs, and that can really hurt the patient while they're trying to recover. We stabilize it to decrease motion. Again, it decreases pain, decreases inflammatory response, decreases the narcotic requirements, and then it helps to mobilize the patient. So over the last several years, in the 1950s, some of you may have seen pictures like this. This is a little bit before my time and probably most everybody in here. But they had these traction wards where patients would have severe injuries. They would put them in traction with weights and pulleys and leave them there for several weeks or months until the fractures healed. Obviously, the thought back then was these patients are just too sick to operate on, and so they need time to recover, and a lot of morbidity and mortality occurred because of this. In the 1980s, the pendulum kind of swung back the other way and said these patients are too sick not to operate on. So we're leaving these patients in traction forever. Maybe we should do something sooner to help them. And that's where this thought of early total care came about. So early total care meaning the patient has a femur fracture, but they have a high severity score, they have lung injury, they have brain injury, all these other injuries, but we fix the fracture right away to try and help them. And we get fat embolus, and it turns out to be bad for the patients, for their lungs, for their brains, and for the patients in general. So this is where this second hip phenomenon came about in the 90s. And the patients were too sick, and we're fixing them, and then we push them over the edge and create more insult. These patients do need some type of stabilization, so what can we do for these patients? We have something else, and that something else is called an external fixator. Anybody familiar, heard of the term external fixator? So these are a couple of examples of some pieces that we use. It's basically like a fancier erector set. But there's pins that we put inside the bone, like a fracture of the femur here. We can put pins in the bone, out the skin on either side of the fracture, and create external fixation with these pins and bars and clamps to stabilize the fracture, reduce the amount of fat embolus that can occur when you put a rod down the femur, and reduce pain and motion at the fracture site and bleeding and all these things. So this is something that a lot of polytraumatic patients will undergo, is what we call external fixation. And from my perspective, if you can get an IV, you can get an X-fix. There's very few times where I can't take a patient back to do an X-fix. They're quicker, they're less blood loss, and they help stabilize the patient and reduce that second hip phenomenon. So you can take a patient like this, put an X-fix on. Once the patient's stabilized, then we can put a rod down the femur, and then we have the patient that can get up and start moving and get back their life. So this is what we refer to as damage control orthopedics, or DCO. Polytrauma patients too sick to undergo early total care. We put on an external fixator, and then we can convert them to intramedullary nail fixation when it's appropriate. So this is kind of where we're at now. The question next is, who should get damage control orthopedics? And there's a lot of things I kind of mentioned before. Trying to avoid that second hit or the second insult. So head injury patients, patients with hypoxia, fat embolism from the fracture site, systemic inflammation, so you can have a patient with a femur fracture. They also have a head injury, and these patients can get an external fixator and then later have a rod that's put down to help the patient. Avoiding that second hit without causing other systemic complications. It's quicker procedure as opposed to a nail that we do later on, less blood loss, and it provisionally stabilizes the fracture. Here's some other indications or things that we look for before or to help determine when a patient comes in. Should this patient, can we put a rod in the femur, or do we have to wait until they are more well resuscitated? These are some labs: lactate, if the patient's intubated, their FiO2, intracranial pressure. All those things are important factors that we look at to determine this. So in summary of kind of hip fractures, femur fractures, it's important to understand and identify those at-risk patients, the patients with closed head injuries, the pulmonary issues, renal problems, and then we stabilize the fracture and then fix it later on. Avoid the second hip phenomenon. Any questions? That's kind of, yeah, please.
The pulmonary insult you talk about, is that part of the ARDS? ARDS?
You got it, yep. That's perfectly right, yep. So patients come in on a ventilator or something, or they're intubated. We know there's some level of, ARDS or pulmonary contusion or flail chest, or, who knows what's causing the respiratory compromise. Those would be a perfect patient to undergo external fixation, allow their labs to improve, to stabilize, to get blood, and then further workup, and then we can fix them later on. So the external fixator has really changed how we practice orthopedic trauma over the last several years, and it's really helped a lot of patients, reducing that morbidity and mortality. So, questions about hip fractures? Yeah, please.
Is there any truth to the matter of an internal versus external rotation, one being fracture versus a dislocation?
As far as a hip goes,
Yeah.
typically they're externally rotated. You can get internal rotation injuries. They're less common.
Okay.
I've seen a few of those. You can get, I remember one patient, he was probably 18 at a football game and got hit, and he came in internally rotated with his legs stuck straight up in the air. And his femur had dislocated, his hip had dislocated and lodged in his obturator foramen, and his leg was stuck straight up. So it does happen, but less common. Usually if they dislocate, it goes out the back is the most common, sometimes out the front, but usually out the back. And then that will, of course, shorten the leg in comparison to the other one. So, okay, very good. Let's move on to a little bit of pelvis stuff. So the pelvis is a very complex, the most complex bony structure we have that I help to manage the treatment of these fractures. It's made up of three main bones: the ilium, the ischium, and the pubis. Those come together, all forming to contribute to the formation of the socket of the hip called the acetabulum. You have the sacrum in the middle with very strong ligaments that attach to the sacrum from the front, from the back. And the sacrum attaches to your spinal column, your lumbar spine, all the way up to your neck. Obviously, a lot of blood vessels, nerves, and vital organs at the lower end of the pelvis as well. So it's really, when you have fractures to the pelvis, again, these can occur low energy, elderly patients, ground level falls can get cracks in their pelvis. High speed injuries can affect the pelvis in younger patients. And there's a variety of different ways we classify these fractures. We'll kind of go into some of that now as we talk more about the pelvis here. What are our goals if you have a pelvic ring injury? One, first and foremost, is to recognize instability and bleeding. If the patient is unstable, they're not responding to fluids and to blood, there has to be a source of bleeding. And if the pelvis is unstable, that's probably your most common place to look, or where you should be looking. Early management to help stabilize these patients is important in unstable fractures. Imaging, and then indications for definitive fixation we'll talk about. So hemodynamic stability and mechanical instability. These are the two big things that we want to assess with patients with pelvis injuries. And the early recognition of either hemodynamic or mechanical instability is really critical to help these patients to survive. Open wounds, you can often see, sometimes you guys may see these in the field, where patients have huge losses of blood from hemorrhage, from open wounds. Externally rotated lower extremities we talked about, and then how do we assess patients' stability in the field as far as the pelvis goes? Anybody have an idea, or do you guys, how do you assess stability of a pelvic fracture right after an injury?
Rocking.
Anybody? Yeah. Yeah, so that's a great one to do. That's the most common one we see. So if you put your thumbs or the heel, kind of the heel of your hand right on the anterior prominence here, what we call the anterior superior iliac spine, are these top bony prominences. You can put one on each side with the patient and just gentle pressure. You should feel, if you push with your right hand, the left hand side of the pelvis should come up towards you. If you push down and it's soft and there's no change on the contralateral side, then you know there's some level of pelvic instability there. So a simple pressure over the pelvis, each side kind of rocking, can give you an indication if there's a pelvic injury. You shouldn't see that with a hip fracture. The pelvis should still be intact with a hip fracture and it should still rock. If you push and nothing happens on the other hand, then that's a good indication something's going on there. And then an AP pelvis, we get that AP pelvis x-ray. Hemodynamics instability, so this is really critical. This is what these patients die of, is loss of blood and shock, because they lose so much blood. If they don't respond to resuscitation efforts, then you have to consider there's intrapelvic bleeding that's going on. If you have open wounds in the field, you can pack those wounds to try and put pressure on those areas to help reduce the amount of blood loss. The key is to reduce intrapelvic volume. When the pelvis becomes unstable and you have an open book pelvis injury, there is a lot of potential space for bleeding to happen, and that's where it's going to go. So stabilizing or reducing that intrapelvic volume is really helpful. Now, we can do this, and we do this in the hospital as well, but you can do it in the field, and this is something called a pelvic binder. Anybody ever used one of these or seen one put on? How do you know where to place this, or where should this be put?
Sit under the trochanter.
That's good. Who said that? Yeah, you get an extra sandwich. Over the greater trochanters, that's right. So the greater trochanter is this bony prominence right here. You can feel it. Some patients are bigger than others, but you should be able to feel that greater trochanter, and this should be centered over the greater trochanter. If you put this too high, which is the most common thing, I've seen them up around the belly. It's not an abdominal binder, it's a pelvic binder. If you put it around their stomach, you will potentially open up the fracture more, and you won't do anything to reduce that intrapelvic volume. You can cause more harm, especially if you cinch it down really tight, if you're not placing it in the right position. So this is what we just said here. These aren't a definitive way we typically treat these fractures. This is temporary. This reduces intrapelvic volume. Patients that are mechanically or hemodynamically unstable should get a pelvic binder. That's really critical, and having this on sooner than later will really help the amount of blood loss, and it helps the patient have less morbidity and mortality. Now, you can do this with a sheet. This is the wrong way to do it with a sheet. There is a great paper by a gentleman, Dr. Rout, who showed pelvic binders with sheets where you can place them on with clamps. They should be broad areas, not tight, and without knots, and narrow sheets are going to cause skin breakdown and other problems. You can cut holes in the sheet to gain access for different reasons, and as well as maintaining some stability of the pelvis. So if for whatever reason you don't have a binder, if you have a sheet or a towel, this is another great way to help stabilize the patient. Things we look for, and I'm going to kind of breeze through a little bit of these as far as x-rays. When we see these fractures, we get an AP pelvis, different views to look at the inlet view, the outlet view. This gives us a better assessment of the pelvic ring. All of these patients get CT scans, and then we classify these fractures. There's a gentleman by the name of Dr. Tile. He classified as, kind of I alluded to, different stability, whether it's rotational instability, vertical instability, or both. And the severity of these goes up the more we trend toward a vertically and rotationally unstable pelvis. Dr. Burgess went through a lot of different compression fractures from the front and from the side, lateral versus anterior to posterior. I'll go through these quickly for you, but you can see the different fracture patterns that occur based on the mechanism of injury. Patients that hit from the side versus from the front. You can have sacral fractures that happen with these in the back that are better seen on CAT scans. Fractures involving the wing of the ilium that can also occur in these fractures, a little bit more high energy from the side. And this is what you see on a radiograph of those fractures. We get all the way up to the LC3, or the lateral compression type 3 fractures, and these are even higher trauma that pushes from one side of the pelvis all the way through and fractures out the other side as well. Obviously, these are very unstable fractures with high morbidity, high mortality, and you get a shift, or what we call a windswept pelvis. You can get fractures from the front, from an injury to the front, which causes widening of the front of the pelvis. This pubic symphysis in the front is strong ligaments that hold the pelvis together from the front, and that can start to open up with compression type injuries. Can also open from the back, but typically from the front because the sacral ligaments are much stronger than those in the front. So you can see that increasing in that kind of wide pelvis there. This is where a binder is really helpful for these patients because it will help close down the front of that pelvis.
When you're putting these binders on, how tight does it really have to be? Are you worried about the bone grinding on each other with this kind of
You could
injury?
potentially over tighten. It's much more common to see them too loose than too tight. So it's kind of a feel. It's snug, but if you're yanking on it and your foot's on them and you're pulling it real hard, you can overdo it. So it's a nice snug somewhere in the middle. If it's too loose, it won't obviously do it. So we usually get x-rays when they show up in the binder. If there's one that comes on, a patient that shows up in a binder, we'll get x-rays in the binder. Sometimes we'll loosen it a little bit, get another x-ray so we can kind of assess the stability of the pelvis. But they can be put on too tight for sure. This is even a further APC3 pelvis where you have fracture opening from the front all the way to the back side as well. Can also get fractures that are more of a vertical shear, so a patient that falls from a height, lands on one foot, it will shear the pelvis and shift the pelvis up on one side while it's staying intact on the other. All of these are obviously very hemodynamically and mechanically unstable. So what do we do? You can see what a binder can do for a patient. See the open book pelvis there. We put a binder on and it really closes down that space. It helps to reduce that blood loss that you get. Is the patient responsive to resuscitation? If they are, great. Then we can start to fix them, plates and screws to put their pelvis back together and restabilize it. If they're not, then they typically get a CT or an ultrasound fast exam to see if that's clear. Patients can have bleeding. Usually this is venous bleeding that occurs in the pelvis, not arterial, and they can undergo embolization through interventional radiology where they can coil off some of those bleeding vessels and help to reduce that blood loss. If the patient does have a positive CT or fast scan where they have blood or something in the pelvis, then typically general trauma surgery will take them for a laparotomy and help to reduce their blood loss or find other sources of bleeding. If the patient's really unstable, there's something that is common that's done in actually Colorado and Denver is something called pelvic packing, where we can pack the wound from the inside and help to tamponade off some of that bleeding. So this is an example of some pelvic packing that's done, and we leave those lap sponges in there until the patient's more stable, and then they can undergo definitive fixation. There's also external fixators for the pelvis, and there's actually ones that are kind of a hybrid between, it's a subcutaneous internal fixator that goes underneath the skin, but these are other tools we can use to externally fixate the pelvis. Those are pins that can go in the bones, stabilize the pelvis from the outside and reduce it, and then we can get the binder off, because the binder on for more than 24, 48 hours can start to break down the skin and have other problems, so it's more of a temporary thing.
The binder, would that cause like the legs to go numb or?
Potentially, if it's too tight, it could, yeah. Leg numbness, I'm willing to put up with much more than a patient that's, doesn't have a pulse or
100%,
blood
but, like,
pressure, but
would
yeah.
that be a sign that it's tight enough or too tight or?
Probably a little too tight if their legs are going numb,
Okay.
yeah. Some mortality risk factors, we kind of touched on these, but patients that are elderly obviously are much more fragile. They don't respond as well and they have less reserves and ability to recover. So patients that are elderly with bad pelvis fractures have a high mortality. A GCS of less than 8, the Glasgow Coma Scale. So if patient's unresponsive when they come in, the lower that is, the higher the mortality. Respiratory rate elevated, low blood pressure, hypotensive patients, high multi-trauma, polytrauma type patients with a high injury severity score do worse with these. These are bad injuries that can cause a lot of problems for patients, and so it's important to recognize them early and understanding the anatomy, where to put the binder, recognizing an unstable pelvis, mechanical instability, and hemodynamic are two really critical things to recognize in these patients. We touched on definitive care versus external fixation and what we call damage control orthopedics. These are all important things to consider when treating these patients. So that's all I have. Thank you for your attention. Happy to answer any questions you guys have, or if you guys want to try the binder or anything, you're welcome to do so. But any questions I can answer about any of that?
You hip and femur specialist? Is that what you?
I'm sorry?
Is it all joints for you, or is it?
Yeah, so I do trauma fracture care in adults mostly. So hip fractures, pelvis fractures, tibia fracture, most any fracture I treat. And then I do hip replacements, knee replacements, and shoulder replacements. So a little bit of what we call arthroplasty is replacing joints, and then trauma. So traumaplasty is kind of what it's termed. So I do a little bit of fracture stuff and joint replacement. Yeah. So, and they often go hand in hand, which is kind of why I gravitated toward that. Because like I mentioned before, patients that have ground level falls and have fractures, a lot of those can need hip replacements done. Proximal humerus fractures that fall, we can do shoulder replacements on elderly patients, help them get them back up and moving and going quicker. So, yeah, that's kind of what I do. So, I appreciate your attention. Yeah, please.
So we obviously have our medical control when it comes to medication, but are there any key indicators or key considerations that you would advise when it comes to pain management of these individuals?
Yeah, that's a tough question. I don't know. A lot of the patients, you don't know what they're on, you don't know their medical history, you don't know what they've taken, so it's tough. I think critically important in the first thing is to focus on the ABCs and DEF like we talked about, but I would probably defer most of the medications to the emergency room physicians that are going to see the patients first. Yeah, I don't really, that's a little bit outside of my spectrum, but yeah.
Gotcha.
But it's important to recognize those and understand what's best for the patient, of course. So. Somebody else had a hand in this. Yeah.
Do you have some backstory to your pictures? The mechanism?
Some of those are from patients that I've seen. Some are from other surgeons that I've worked with over the years. Ski injury, I think a lot of motor vehicle accidents. The worst accidents I've seen have been motorcycles and train. Actually, I've seen a few patients that have hit by a train and survived somehow. So yeah, some of these patients can just be, in a really bad place when they come in, and so that's why I love trauma patients. I love joint replacements because it's taking patients from a vulnerable state where they have limited function, a lot of pain, and can be broken and beat up, and you can help them get back their lives and turn it around. So it's really rewarding to help them. And you guys are the ones that see these people long before I do. So you guys are on the front lines of seeing these patients, helping. The sooner we can recognize these injuries, the sooner we can provide treatment for these patients, the better the outcomes are. So you guys are really critical in that important part of the team for sure. So, thank you for what you do. Thank you. All right. Get some more lunch, have some cookies or whatever is left, and any questions later, I'm happy to answer them. But like I said, I work out of Salt Lake here in Davis, Holy Cross Hospital, so happy to help treat your patients that you guys see. So, thank you for your attention.
He said he wanted to leave a short
Typically a hip fracture. Femur, if it's more of a femoral shaft, you'll see a lot of swelling right in the thigh. And if you try and move it, it's like they have a weird joint right in the thigh. You just really pelvis fractures. Don't put a binder on a hip fracture patient. That can cause a lot of pain. If you put it right over where their fracture is, and the fracture's through here, and the binder's put in the right spot, it will impact that fracture and cause it. And it won't help.
Yeah, no, this
So the key to when we should use the binder is when you do that rocking test. If you push on the pelvis and you don't feel it on the other side, that's an indication for a binder. I've seen binders put on hip fractures.
No, you're our medical.
And they really, patients are really, that doesn't help.
Oh, okay.
It usually causes more problems. So,
Not just ours.
My husband
Oh,
has
yeah?
a rod in his femur. He said that should get removed because it connects the hip.
Yeah, that place is easy.
How does the rod connect to the hip?
So I typically don't remove those rods unless there's a reason to do it.
Oh, really?
I does it connect all through? It connects, so this is actually about for a tibia, but I kind of brought it for a demonstration. So a nail that goes inside the bone, what we do for those is we create a little hole up here in the greater trochanter, and we have these instruments that put a guide wire down. It goes inside the bone all the way to the nail. Depending on where the fracture, I don't know what kind of